who's an associate professor at the University of Toronto and part of our cardiothoracic division at the Department of Medical Imaging at the PMCC. And we're going to come back to this patient risk thing, and he's going to talk about cardiac CT, can it be used for patient screening. Sebastian, please.
Thank you, Bernd. Dear ladies and gentlemen, thank you very much for inviting me and presenting you some data on cardiac CT and the screening. It's not really one of these fancy talks you have heard before the lunch, but I think it's groundwork and needs to be talked about. So here we go. Where's the next? So the outline of this presentation is about the pros and cons of screening overall, as we're talking now, what can we do with cardiac CT and screening, and then what is the conventional coronary artery risk assessment in the office, and what can or where can cardiac CT fit in, and then the two CT technologies everybody I think knows about, calcium scoring and CT angiography. So a screening test per definition is really, we look at patients or at people, so no patients, at individuals without signs or symptoms of any kind of disease. The advantages are only two. They can detect medical conditions at an early stage before symptoms present, and in an optimal setting, if you do a screening test, we can save lives or years for these people. And now, quite interesting, there are a couple of disadvantages that are mostly associated that these tests we can offer any patient are not perfect. So what do we have? We have false positives or false negative results of these tests. We have to involve costs and medical resources to apply to individuals that don't have any kind of symptoms or diseases. Then we have adverse effects that are associated with these tests, like stress for the patient, what will the test show, and other more hard effects like radiation exposure. We have unnecessary investigations and treatment of false positive results and incidental findings, and we have a false sense of security caused by a false negative result, and this may finally delay the diagnosis. In daily routine, everybody, I think, is really aware of this. The patients are classified or categorized by the Framingham risk assessment, and this looks at different risks the patient is on for a 10-year predicted to get any cardiovascular events. And if you look at the tables, you have the conventional delineators in there. So you have the age of the patient, the smoking habit, the cholesterol amount in his blood, and so on. So everything is assessed more or less non-invasively. And then you come up with a risk stratification. So you have patients at a low risk, so they have less than 10% of an estimated 10-year risk, intermediate risk category, and a high-risk group of patients. But, and this is the most important thing, if you look at these tables, 50% of patients with an acute myocardial infarct have not any classic risk factors. So this risk assessment is helpful for 50% of the patients, but what is with the other 50%? And this is where the calcium comes into play, because it was found quite early on in that there is a close correlation between the atherosclerotic plaque burden and the extent of the coronary calcium. And this is shown here, where they examined 13 hearts, and they did a CT with a histopathology, and they found a close relation between the calcium, it's down here, and the sum of the plaque areas. And they found quite a decent linear correlation between these two entities. And this made, or on this basic chart, the whole idea about calcium scoring is based upon. And finally, this leads in the 2010 recommendations of the various active groups in this field. All the groups are here, that they recommended the calcium score for patients that are at an intermediate risk for coronary heart disease, and in a subset of patients with a low risk that are low-risk patients by themselves but have a family history of premature coronary heart disease. But it is inappropriate to repeat the coronary calcium score every 1, 2, 3 years just because the patient wants it or not. And this is how it looks like. What are we doing, basically, if a patient is referred to us? So the patient preparation is simple. We don't apply any medications, any drugs. Patients are usually asked to withhold caffeine or smoking 4 hours prior to the examination. We don't need any IV access, no contrast media is applied, the patient is equipped with an ECG, and the patient is asked to hold their breath for a couple of seconds. Then the result is what you can see in this movie. We get a 3D volume of the heart, usually 3 millimeter slices, where you can nicely see all these calcified areas. And if you see it here, circumflex coronary artery, run one more time. Here, the LAD, circumflex coronary artery, huge amount of calcium. And how does this fit in the clinical management? Because if you look at the recommendations based on the Framingham risk classifications, again, you have the low risk, intermediate, and high risk groups, and the share of people that are usually found in these groups. It is recommended for the intermediate risk group that you should further stratify the risk of the individual patient, and here the atherosclerotic plaque burden is recommended. So, and this is, if you remember the slide beforehand, and the linear correlation between calcium score and atherosclerotic plaque burden, this is where the test comes into play. So what are the results? For a coronary artery calcium score, if we have a score less than 100, this is typically associated with a low probability of an abnormal perfusion scan on any nuclear stress test, and less than 3% probability of a significant obstruction on cardiac catheterization. And if you now see the survival rates, where you have the time of an event and the cumulative survival, you can see that a low calcium score, basically 0, leads to a pretty good survival. And if you have a higher calcium score, the least is your survival rate. And another group categorized it for different tertiles, where you also have an increased the annual risk of cardiovascular events. And in a nice overview and review paper published quite recently, they classified the relative risk ratios for average, moderate, high, and very high risk based on different number of the calcium score. And they used a different subset of calcium scores. And you can still see the relative risk increases with the amount of calcium you have. But all these absolute numbers still don't take into account that with a different age, you might be in a different population, and it is quite normal to have a calcium, which not necessarily put you in a higher risk group compared to your peers. So I think a 40-year-old male will have a lower amount of calcium than a 70-year-old male. And this is where the percentile curves we are usually reporting in our reports comes into play. And this is quite an important work. They included 25,000 male subjects. There's the same thing for females. Sorry for putting only the males down here. Where they said what is a normal range, what are the different percentiles, what this age group shows on a calcium score. And if you now add this to the recommended risk classification, we could see, and this is published as you can see down there, that if you have a low risk or low calcium score, you can be treated or handled as a low risk group. But if you have extensive calcification, you really should be more aggressive in the workup of this patient. How does this relate to any ethical differentiation between different populations? And I think especially Toronto, it's quite important to talk about this. So if you look at these data out of 6,722 men and women that were included in the multi-ethic study of atherosclerosis, there was no difference found between different races and ethnic groups in the predictive value of the calcium scores. So it doesn't matter which patient you're dealing with. What does a calcium score of 0 means? It is principally quite favorable. So if you go for the meta-analysis of 29,000 patients, the annualized event rate was only 0.1% after 50-month follow-up time. But another study, a little bit smaller for sure, showed that 41% of all future vascular events occurred in patients with a calcium score less than 100, and 17% of all cardiovascular events occurred even in those patients with a calcium score of 0. So a calcium score of 0 is not necessarily, there's no atherosclerotic plaques in this vessel. And this is pointed out in this slide, where you can see the invasive catheterization here and the CT angiography over here. And you can see, although there is considerable and significant stenosis within these vessels, you don't see any calcified plaques. And this is that the calcification is only one component of the whole process of the vascular changes, and it does not necessarily have to be associated with a plaque and a stenosis. And this is again from the initial study with the explanted hearts, where they really correlated the amount of calcium with the plaque burden. And this is the typical finding, where you have the distance from the coronary artery here, the calcified plaques over here, and the overall plaque burden over here, and you can see more plaque burden overall. But there were also a number of coronary arteries that showed no plaque, no calcified plaque, but still a considerable amount of plaque burden overall. So, and this points out calcium score 0 does not necessarily mean there is nothing in the coronary arteries. One drawback on the screening tests is the radiation application to the patient. So we harm the patient if we apply this test. And the published studies show a huge variability in radiation dose applied for a calcium score. And if you go now for a median value of 2.3 millisieverts for the coronary calcium score, then the authors calculated some, or based their calculations on the assumption that they did every 5 years a screening, men starting at the age of 45 years, and then you can see that the cumulative radiation-induced cancer risk would be 42 per 100,000 screened patients in male and 62 for females. So there is some, at least, calculated and estimated risk associated to this kind of test. Another thing, incidental findings. The prevalence for incidental findings is quite high, 10 to 60%. It can reach from nodules in the lung parenchyma, which we usually report within these reports, and only a subset of these nodules are really worrisome, so they are larger than 1 centimeter. But still, some of these nodules require follow-up, and this also adds on more costs and insecurity for the patient. Others are aortic disease, lymphadenopathy, or abdominal findings that needs further workup. What is calcium score in the symptomatic patient? We're now leaving the part of the screening piece of it. And in this study, 2,115 patients were included. And the calcium score was compared to invasive angiography. And the overall sensitivity of the coronary calcium score to predict any major or significant arterial stenosis was 99%, but the specificity was only 28%. And if you only included these areas where the calcium score was above 100, then the sensitivity decreased to 87 and the specificity reached 79%. So in the symptomatic patient, I think coronary calcium score is not really the test to go because it does not necessarily help you anything. What is now with the CT angiography? As we have heard, calcium is not always the key, but the statement is quite clear in this. For screening purpose, in an asymptomatic patient, CT angiography is not recommended yet. So this is no test really to suggest to the patient. In general, how does it work? Usually patients are asked to withhold caffeine and nicotine 8 hours prior to the examination. We need a large IV access to establish a flow of 5 to 6 cc's per second. Beta blockers are usually applied to reduce the heart rate less than 60 beats per minute. The examination reveals then a 3D volume, the coronary arteries with the 0.5 millimeter slices, and it's usually quite a short breath hold, rather 8 seconds. And the radiation dose is approximately 4.5 millisieverts, what we gain overall, the population, what we see. So what is the CT angiography performance? Just to give you here a summary of some previous original articles. And if you here see then the positive predictive value of a significant stenosis, it is varying between 61 and 89%. So we're not really there yet to really exclude something with 100% chance. But if you go for a negative predictive value, CT angiography is quite good. So CT angiography should be recommended more or less to rule out coronary artery disease, but not to rule in or really evaluate for coronary artery stenosis. So in conclusion, cardiac CT for screening, the coronary calcium score is recommended by the guidelines in patients with an intermediate risk or patients with a low risk themselves, but with a strong family history of premature coronary artery disease. CT angiography of the coronary arteries is not yet recommended as a screening test. Thank you very much.